us who attended the conference also do have access currently to the presentation. So if there's something that you really want to know in a time urgent manner, please reach out. Next year's conference will be in Denver, Colorado in the last week of February. And then I did put here at the bottom of the slide, although I can put it into a separate link in the chat maybe. So this is a public link to a YouTube of the Martin Delaney presentation by Rebecca Dennison, which was done at the opening session, where she covered like her experience as a woman diagnosed with HIV, actually living in San Francisco in the early 1980s, and just a really moving presentation, and is publicly available in advance of other elements of the conference. So feel free to check those things out. So last week we covered a lot of the cardiometabolic complications, everyone's favorite new drug, semaglutide, and the impact on people living with HIV, and also some early data from letermovir, which is a CMV-specific medication that showed some promising data in a prematurely terminated clinical trial. I did hear from one of the lead investigators over the last week that actually Merck is interested in refunding that letermovir trial. So it was terminated after just an enrollment of about 40 participants after an initial goal of 180. But they terminated it early based on a biomarker of TNF receptor 2, which they then turned out to not maybe be a reliable predictor of the outcomes they were looking for. So they are now hopefully going to pursue a broader trial with possibly pharmaceutical sponsorship. So we'll see. So I thought today I'd start off with some things from the hepatitis session. So the first is an abstract from the CNICS system. So this is the CFAR network of integrated clinical systems. And they looked at hepatitis C incidence between 1995 and 2023. They specifically included the following sites, including JHU, Case Western, Fenway Health, University of Washington, UNC, Chapel Hill, UAB, and UCSD. And they included all people with HIV with a negative hepatitis C antibody at baseline, and any test done at or greater than 12 months after that initial test. And for that they included both hepatitis C RNA or HCV RNA or HCV antibody. So their primary outcome was incident hep C, and they stratified their analysis by initially identified HIV risk factor, which is a variable that's entered into the CNICS cohort at enrollment. And then they calculated a crude incidence rate and then an adjusted incidence rate ratio, and analyzed based on baseline characteristics, HIV viremia as their primary things they were investigating. And they divided the time group into 3 different eras: one, the 1995 to 2005 era, which they call the interferon era, although for those of us at the end of that, it was the do nothing era. And then 2006 to 2014, which was the early directly acting antiviral era with like boceprevir, lots of rashes. And then 2015 to 2023 are very highly, extremely active and well-tolerated direct acting therapy era. So what did they find? So they had 20,917 individuals who contributed more than 170,000 years of person years of follow-up. The cohort is predominantly cisgender male, so it's like 81% male, median age of 37, and HIV acquisition risk is predominantly men who have sex with men. So they divide their acquisition risk categories into non-overlapping groups. So you can either be an MSM or an MSM with injection drug use. Those are 2 different categories. So the MSM with injection drug use are 4% of their population, and MSM are 61%. And people with injection drug use in general are 2% of their population, and about 54% of them had baseline detectable HIV. So, and again, this is spanning 1995 to 2023. So what they saw were the highest rates of hep C incidence were in people with injection drug use at an incidence rate ratio of 28.2, and men who have sex with men with injection drug use, which was 20.4. But the really eyebrow-raising finding was that in MSM without injection drug use, there was increasing incidence through the time periods, from 3.5 to 7.6 per 1,000 person years over the period of follow-up. And so this 2-fold increase in hep C incidence among men who have sex with men without injection drug use, despite very stable rates in the population identified as those with injection drug use during the same period of time, was really what the authors highlighted as, a point that needed some consideration for what is driving this, and how can we think about targeted prevention efforts in this population. Again, the rate is much lower than among people with injection drug use, but still the increase is really what was most notable. One other thing from the hepatitis sessions was there was an analysis of the hepatitis B clinical trial looking at Heplisav, which is the CpG adjuvanted vaccine, as compared to Engerix-B, which is the alum adjuvanted standard Hep B vaccine. These analyses have been presented previously and published, and Andrea's on one of the leads of the study team. What they presented at CROI was just the durability of the response at 72 weeks. And what they found was 3 doses of Heplisav was more durable than 2 doses, which was more durable than alum. So just to summarize these 2 hepatitis presentations, and then see if anybody has any thoughts about them. One, this idea of screening for MSM and interventions, specifically targeting the reduction of Hep C incidence, and then also the Hep B CpG vaccination. I mean, the schedule is 2 doses. So the study tested 3. There was a slightly higher rate of outcomes that were positive, like here durability in the 3 dose, but unclear whether that's enough to up the recommendation of giving an additional dose. In fact, is not currently the schedule. So I don't know if anybody of our hepatitis people has any comments on the Hep C incidence, if you think that's an artifact or an exciting finding. Dave?
I muted just in case no one else said anything. But I think the Hep C incidence is an interesting finding. Those are hard practices to measure, and so it's always hard to know how much confidence to put in them. But the obvious interpretation is that this inhibition amongst persons who are more and more convinced of the U equals U kind of principles have led to increasing incidence of other conditions like HCV. And the other possibility is that changes in drug use practices and acknowledgement of drug use practices has shifted, but it's hard to know. I think what didn't happen is that, unlike in other countries where expanding HCV treatment led to corresponding reductions in incidence as a sort of treatment for prevention kind of a thing, that has not clearly not been experienced.
Yeah, that was one question I had about it. Was I thought from the presentation that they defined categorization of risk based on baseline. So I did wonder if there was some crossover in terms of like new acquisition of injection drug use behaviors.
Yeah, and it's always been hard to know. A very little misclassification goes a long way with a risk factor that is poorly ascertained anyway and dominating, like injection drug use. So it's such a strong risk factor. It's hard to ascertain. It's misreported, and so I think the value is the sort of stability of the measurement, but I'm not saying there's something wrong with their study. I just think these are hard things to make too much of, but it differs from what was observed in several European countries where incidence reduced. So,
yeah, no, and
yeah, thank you for picking hepatitis topic.
I think the other thing I thought about it was just like, I do have a couple of MSM who progressed to injectable use of meth at some point in their time with me, and that was usually pretty obvious because meth is a pretty good. You can sniff it out pretty quickly in a lot of ways, but I think in my discussions with people and what they're doing for their, like, how frequently am I assessing their true risk, and whether or not my questions work, or if I should just be doing more screening.
I think the screening makes sense personally based on these data, and I think many people are already doing that. And yeah, the shift to different detailed studies of small populations, unlike this big database kind of study, have underscored the importance of chemsex and shifts in risk practices, in particular amongst men who have decided that they were going to be more, sort of less inhibited, and because they're not worried about getting HIV, or they're not worried about getting HIV super infections or anything else. And so that's a message that keeps coming out, and I'm sure is robust and maybe what's behind these population data.
Yeah, it's so easy to screen and easy to treat, but I think err on the side of screening. I agree with everything Dave said. I was just going to comment quickly on the 2 versus 3 doses of Heplisab-B. I would just point out that the other things that were associated with reduction in response to the 2 doses were very classic things associated with low response, low CD4 count, and higher age. So if you have an older individual with a lower CD4 count, even though it's not standard, I would probably give a 3rd dose of Heplisab-B. So I think in a person under 40 with a high CD4 count, there is literally no difference in that population between 2 and 3 doses, and it would be hard to argue one should give a 3rd dose to a person in that age range. But those people are also probably vaccinated as infants against hepatitis B as well. So anyway.
Thank you, Andrea. And Sean.
Yeah, just real quick on the screening question in MSM, the HCV guidance actually recommends annual testing for all persons who inject these drugs, people living with HIV who are men who have sex with men and have unprotected sex. So even without the risk factor for drug use, or protected sex with other men is considered indication for annual testing for hepatitis C, in addition to MSM who are taking pre-exposure prophylaxis.
Yeah, no, that's super helpful, Sean. And it's one of those things that I know that I am not as on top of. And I don't know, Joyce could probably mention, is if it comes up in our, but I guess that would be a hard thing to have in your dashboard, because it requires more identification of like sexual practices and things like that.
Yeah, I mean, one thing, so Randy Boardman and actually Ruth Howe, the fellow, oh, sorry, that's a different project. So Randy and I are working on the care gaps together, and I've actually submitted a JIRA for that to happen. And one of the things that would need to happen would be for us to have a consistent place where people are reporting about sex behavior.
Yeah.
So there are different opportunities for that. And we can have a conference once we're further along with this care gap project. But that is the issue, is where will people consistently with a discrete checkbox, or something that will go to a flow sheet, note these kinds of behaviors, then they can be included in the denominator for different evidence-based screening and things like that.
Great, that's super helpful. Well, awesome, thank you. And so other than that, I should just also mention that from the prevention space, there were a couple of presentations that DoxyPEP works, the uptake is good, the maintenance is good, and there's no substantial adverse effects, but I didn't summarize that data very well here today, but maybe we'll revisit it at another conference. Any other comments? Okay, great. So I will move on to another prevention RCT. So this was a HPTN 094, which was a 26-week randomized controlled trial of integrated strategies for people who inject drugs. And so this was a randomization to either pure navigation alone, or with a mobile unit service center for care and pure health navigation services. And I highlighted it just because I thought it resonated with a lot of the things that have been worked on here. And they had primary outcomes at 26 weeks, which were on maintenance medication treatment for opioid use disorder, which was defined by both an active prescription and a positive urine screen, so a biomarker for retention, increased rate of viral suppression for people with HIV, and an increased uptake of PrEP for people without HIV. So what did they do? So they enrolled adults greater than 18 with opiate use disorder willing to start medication-assisted treatment. 25% were female, only 10% were less than 30 age, and the majority were in unstable housing. They recruited in Los Angeles, Houston, Washington, Philadelphia, and the Bronx. They have this peer navigation model with a strong basis in science that they described in some detail with motivational interviewing and other components. That is in both the active placebo arm and in the mobile outreach unit arm. And they overall enrolled about 450 people. So there were 38 people with HIV, and people without HIV was 409 individuals, and their statistical analyses are in that group. They had retention of 85% through 26 weeks, which was pretty amazing. And if they excluded people who either died or were incarcerated, they were up to 90% retention at 26 weeks. So in their people without HIV statistical analysis, there was no difference, 7.8% versus 7.4%, based on this like two-step confirmation of active use of maintenance of opiate maintenance medication assisted treatment between the active placebo arm and the intervention arm. There was a slightly higher rate of PrEP use, 2.9% versus 5.4% in the two arms. And then they showed their all-cause mortality data. So here, as the presenter said, and I like totally applaud this, there is no statistical difference, but for the 7 individuals who are still alive, there's a major clinical difference. So they saw 10 deaths in their active control arm and 3 in their placebo arm. 3 in their more focused intervention arm. And they're trying to do more work to see what they can do to further increase this outreach and to enhance uptake of some of these other interventions. They did it by self-report use of medication-assisted treatment. They were at 10 to 11% in their group by this rigorous definition of adherence to with a prescription and UTOX, they were lower. So still a long way to go, but if this were validated that you could actually prevent deaths, I mean, I think that would be a very substantial finding. But those were the overall results. I don't know if Sean or anyone has any thoughts about.
Yeah, I think being unhoused is just, I mean, I think it's unimaginable, you know, the things that people are unhoused have to deal with every day. So that, I mean, one can understand how coming to fill a prescription for MOUD might fall down on the list of competing priorities, including death, apparently. And so we do know that social support is associated with improvement in a range of outcomes. And so that I imagine that patient navigation, peer support, and then probably these relationships with providers on the mobile van, which help people feel like people and may address hopelessness and some of the other things that probably increase the risk of death, may be causal to why the intervention may have been associated with death prevention. But exciting to see this work. It's really hard work to do.
It is really hard work, and I think they should be applauded for doing an active control, right? They had peer navigation support even in their placebo arm, which clearly would not bias them towards having positive results, but I think is the right thing to do when you're trying to help people. And Siobhan, to your question, there was no financial incentives. I don't believe, I don't recall that from the presentation, but it's another good question. Okay. And then the next one I was going to talk about, so this one is just part of the continuous infiltration of all talks about what we should be thinking about in our global health response. This was assessing interruptions in treatment, or IIT, and mortality among children living with HIV less than 15 years of age in PEPFAR supported countries, but for the fiscal years of 2021 through 2024. So children represent 3% of all people living with HIV, but account for 12% of deaths. That was a fact statement that really took my breath away. Addressing interruptions in treatment in children less than 15 years Here using, sorry for that typo, monitoring and evaluation reporting data, or MER data, from 53 PEPFAR countries. So as part of the introduction, they also just highlighted the PEPFAR impact. So 26 million lives saved, as we've already discussed on prior conferences, but the point of 7.8 million babies born HIV-free is one that just cannot be overstated. And then in FY24, they were providing antiretroviral therapy to more than 500,000 children. So what did they find? So they defined interruption in treatment as no clinical contact for 28 days. And the reasons for this could be categorized as death, transferred out of the region for which the data was being collected, refused, meaning stop treatment for any reason, or expressed a desire to stop treatment, and unexplained, which was classified by duration they've been on treatment prior to the interruption. They also assessed what they called return to treatment, or RTT rates. And they looked at the classification of mortality whenever it was observed as HIV-related, other natural causes, non-natural causes, or not reported. And so there were, among 523,285 children being supported by PEPFAR during this 3-year time period, there were 21,325 interruptions in treatment. Typically, interruptions occurred were more than 6 months after ART interruption initiation. So among children who'd been on ART for longer than half a year, except for in infants who were less than 1 year of age, when it typically occurred within 3 months of initiation. Death was disproportionately the reason for interruption in age less than 5 children. So between age 1 and 4, 7 to 10% of all interruptions in treatment were attributable to death of the child. And in those less than 1 year, 13 to 19% of interruptions were attributable to the death of the infant. And among these deaths, HIV-related mortality accounted for more than half of the deaths. So, and the one other thing that they highlighted was that interruptions occurred more commonly than return to treatments, highlighting the need to not lose children from the start. So once a child has been lost to care for any reason, it appears to be a much more significant challenge to bring them back in. And that just gives some information about how we can best reach children and to keep them on suppressed and prevent these bad outcomes. Again, I think, the statistic of 3% of the population and 12% of the deaths is really remarkable. It is the kind of metrics that we need to surface for those who are making decisions. And also just the quality and information of the PEPFAR database, and how we can then make really smart decisions about how we implement programs and where we try to prevent losses to follow up. Feel free to put up a hand or unmute at any point. Otherwise, I will roll through to a slightly more optimistic from the children and adolescent period. So this was an analysis of lenacapavir in pharmacokinetic safety and efficacy in adults and adolescents in Purpose 1. So I will say this was a, sorry, there's lots of typos I'm seeing here, but it was everyone was very excited about this presentation. It was kind of a little bit of a disappointment. So this was just subgroup data from Purpose 1 that's already been published in July of 2024. That was, the scientific finding of the year, that lenacapavir had full preventive efficacy in cisgender women for against the acquisition of HIV. But this does do a very important thing. So there's a historical requirement for adolescents to have a separate 25 to 50 individual trial after a new agent is approved that has led to substantial delays in access to care. And for anyone, if David Griffith or Allison or Renata, any of the people who Leon have followed people through adolescence, we know that this is a really important time where there can be many, many challenges to oral ART adherence. So delays in access to novel interventions like injectable therapies that have major consequences. So this was the first phase 3 trial to specifically and intentionally include adolescents. And there were multiple stakeholders engaged at different points in both the development and implementation of the trial, including community consultation to guide how consent or assent would be obtained, and emancipation of certain adolescents for consent on their own behalf. So there were 124 adolescents, and again, the age range here is only 16 to 17, so we're not getting that low here, but we're going from 18 down to 16, 56 of whom were assigned to lenacapavir, and basically what they showed was that there was no substantial difference in the PK, and obviously there were no HIV acquisition events in anyone, so there's no specific efficacy data to be gleaned from this particular analysis, but it's likely that moving forward, they will be able to label based on weight at a cutoff of 35 kilos and not age, which would be a substantial benefit for people caring for people at that adolescent transition. So that was exciting and good to see, although again, not massive advance of data, but important clinical trial approach to allow one of those things that can be done with a thoughtful approach to then really dramatically impact access to treatments for populations who need them the most. Another trial looking specifically at a population that's often not included in clinical assessments was the Dolphin Moms trial. So this looks at the pharmacokinetics of dolutegravir and HIV viral suppression with TB preventive therapy strategies during pregnancy. So this is addressing the gap of safe and effective TB prevention therapy during pregnancy, despite the known increased risk of progressive disease that occurs peripartum and postpartum among women of childbearing age. So this was an open label phase 2 trial that enrolled 50 pregnant women between 20 and 34 weeks of gestational age with HIV suppression on a dolutegravir-based ART regimen. And they randomized them 1-to-1, so 25 in each group, to 1 HP, which is daily INH and rifapentine, and 3 HP, which is weekly INH and rifapentine, with treatment for 3 months in both groups. And in both groups, they escalated their dolutegravir dose to twice daily. So the study population was Black women in their 30s with a BMI between 30 and 32 and a median CD4 of greater than 600. Dolutegravir trough was not different at day 1, but declined substantially at day 17 and was stable at day 52, so showing the impact of the rifamycin addition to their regimen. But a simulation analysis suggested that dolutegravir BID was required with 1 HP, but actually you could go to dolutegravir once daily dosing with 3 HP. So now they've enrolled an additional 25 pregnant women on 3 HP and daily dolutegravir to try to do empirical confirmation of this simulated analysis. And hopefully that would get us to a point where we'd have an alternative regimen, a shorter regimen for TB preventive therapy that can be maintained with once daily antiretroviral dosing. So that was a new finding presented by Jyoti Mathad, and this is work that Amita and others and Kelly Dooley and others and Ethel have all contributed to over time. The next one I wanted to highlight was actually in a poster. So this is integrase inhibitor versus protease inhibitor based therapy for people with advanced HIV disease. So this, now we're shifting gears to HIV, and I can pause, but please just put up a hand or unmute. Always happy to have discussion. So this is shifting gears now to HIV. European investigator-initiated open-labeled multi-center non-inferiority trial comparing BIC-FTAF to darunavir-CoV-FTAF in people living with HIV with advanced disease. So the specific goal of this study was to address the fact that most registrational trials actually include a small population of people with advanced disease. And so we are left often, sometimes we get actually restrictions around prescription, like as seen for rilpivirine with viral load greater than 100,000. And sometimes we get no restrictions, but not a lot of data to know what will happen in the setting of advanced disease. So here they specifically sought to test that with an investigator-designed trial. Their primary outcome was time to failure, and they defined an insufficient response as less than 1 log viral decline at week 12 or a viral load of greater than 50 copies at week 48 or a clinical event. And so here I've taken, they were randomized 1-to-1 for 48 weeks to either BIC-FTAF or darunavir-CoV-FTAF and enrolled 442 participants. They were 81% male and 62% white. The CD4 count was less than 100 in 86% of the participants with a median CD4 count of 41. and a viral load of greater than 500 K in 45% of the participants. So this is truly a population that has advanced immune depletion, and a good one to study this comparison in. So you can see here in the figure taken from the poster that there's, as expected, with the somewhat more rapid decline in viral load observed with integrase inhibitors, overall comparable rate of achieving viral load less than 50 copies in both arms of the study, and the probability of attaining a CD4 count of greater than 200 in the Kaplan-Meier curve is nearly overlapping. So the takeaway from this is that BIC-FTAF works well in this setting of advanced disease, which is overall really a reassuring result. And while not something that we weren't necessarily doing, it was something that we didn't have like a ton of data to support. And this trial just really underlines that for those of us who like came of age in the darunavir is the savior time window, BIC-FTAF does well for patients in it with advanced disease also. So overall reassuring data, and nice to see the study done. Next, I was going to go to a couple of studies reporting cabrolpivirine in the wild. Unless anybody has anything they would like to say, but I will go ahead and dive in. So the first is abstract 683. So this was presented by Christopoulos et al. From Monica Gandhi's group at Ward 86. So data on 437 individuals who started cabrolpivirine through clinical care. The cohort had a median age of 45. They're 90% male, 46% have unstable housing. Then they reported their data based on both whether you had viremia at initiation of cabrolpivirine, which was a characteristic of the Ward 86 population that's not recapitulated in other cohorts, or if you were virally suppressed. So they saw a rate of discontinuation of Cabril of 16% of those with viral suppression at initiation, and 15% of those who started cabrolpivirine with viremia. So when did they discontinue? The median number of injections prior to stopping was 6. 10% of them discontinued after a single dose, and 30% of the discontinuations were after more than or equal to 10 injections. So what were the reasons for discontinuation? So in the viral suppression group, where there were 47 discontinuations, pain or other side effect was the leading reason for stopping the therapeutic. In the viremia group, where they had 22 discontinuations, virologic failure and care disengagement were the leading causes of stopping of cabrolpivirine. Although, interestingly, many achieved suppression on alternate ART. And I've actually thought about this a bit with some of our most hard-to-reach patients, that if you get them all the way to an injectable therapy and they go through, like, to the witnessing of you really advocating for them to receive a therapeutic and then trying it, in some cases, I think it can actually help with oral adherence, both before they get it and maybe potentially after, as observed here, where they had people who had not been able to suppress previously who were able to suppress after failing an injectable, after an injectable regimen failed them. So that was one experience. Then there was also from just down whatever that famous highway is in California, from UCSD, there's another presentation, nearly exactly the same size of patients. So this is from the UCSD Care Center, where they had 465 individuals who started on Cabril. 27 transferred out of care, and 92 of them, which was 20% of their overall population, discontinued treatment and were included in their analysis. So their median age was 38, 21% of them were female sex at birth, which is a bit higher than the other cohort. 90% had a viral load of less than 50 at initiation, so they were not doing as much of the focused effort to try to expand the use of Cabril to people with viremia. So the median number of injections prior to discontinuation for them was 4, as opposed to 6 in the other cohort. The time on cabrolpivirine was a median of 164 days, so just less than half a year. And the majority of their cohort were on every 2-month dosing, which I think is important to think about if you think about who's discontinuing. If they're discontinuing to pain, would that be reduced if you were every 2 months or 1 month? But most of the participants in this study were on every 2-month dosing. So injection site reactions or side effects were the most common reasons for discontinuation. Also cited were insurance changes and difficulty in making it to all the appointments to get the injections. They have a high rate of continued viral suppression with switch back to oral INSTI, suggesting that that strategy is a good one for people who are dismounting cabrolpivirine with while under appropriate medical supervision with no other issues in their care. Then there is a much larger analysis from a cohort. So those two analyses have the benefit of, they're sizable, more than 400 participants in each one, and, have like clinic level data, disadvantages of being single site studies and other caveats for the specific characteristics of the population, the providers who are making the decisions, but provide really some interesting data. So we have 15 and 16% rates of discontinuation from Ward 86 and 20% rate of discontinuation from UCSD. And this is an analysis from the TRIO Health cohort of 1,198 individuals who initiated cabrolpivirine with follow-up between 2021 and 2024, and a median of 12 months of follow-up in this study. So for them, the median age was 43, 77% for male, and all were suppressed at initiation because this is where insurance approval and routine clinical care is guiding the use of this medication. And at the end of follow-up, 79% remained on the injectable therapy. So 69% of the individuals in the study had no delayed injections. So overall, in this sort of real world experience, close to 70% of people were able to maintain on-time injections through a median of 12 months of follow-up in this 3-year period. 89% of all injections, so that's considering individuals, and this next statistic considers all injections. So if you were a person who was late for your injections and you were late for 5 of your injections, you would drive up this number, but not the number of individuals with late injections. But this was actually better. So 89% of all injections were considered on time. So overall, again, in this large cohort of more than 1,000 people, in the real world, most people are getting their injections, are getting most of their injections on time. So they observed confirmed virologic failure in 15 individuals at 1.6%. I will just put that number in your head of 1.6%. At a median of 7 months after initiation, the interquartile range for the time to failure was 3 to 12 months. 8 had follow-up of more than 2 months on a subsequent regimen, and 75% of them, or 6 of 8, resuppressed on an oral regimen. There were injection delays in 4 of the 15, or 27% of the confirmed virologic failure. So you're like, we know why, with a median of 5 days of delay in the injection. But in the overall cohort with no virologic failure, there were 31% of the participants had injection delays, and the median for their time to delay was 9 days. So there's not really a signal here that delayed injection is what's driving the rate of confirmed virologic failure. A genotype was available at confirmed virologic failure in 5 of the 15 individuals, and rilpivirine resistance was identified in 3 of the 5, and cab resistance in 1 of the 5. They didn't report, at least as far as I could tell, the amount of resistance present at baseline in those with confirmed virologic failure. They did report that in the overall cohort of 1,100 participants, for those for whom there was genotypic data available, about 2% did have evidence of baseline resistance to rilpivirine or NRTIs. So overall, this gives us a 1.6 failure rate in a large real-world implementation of cabrolpivirine, which is very, very similar to the clinical trial rate of failure of this regimen. So the next study I'll talk about briefly is the CARES trial, and then we can sort of pause and talk about cabrolpivirine. So this is a phase 3 open label non-inferiority study that sought to evaluate the safety and utility of switch from first-line oral ART to injectable long-acting ART that enrolled at 8 centers in Africa. So they were really trying to see whether we could move this injectable approach into settings where we have lower levels of resources for repeated virologic monitoring and other things that seem important while you're implementing long-acting therapeutics. So exclusions included prior virologic failure, pregnancy, or hepatitis B co-infection. And those who were enrolled were randomized 1-to-1 to either continue their oral ART or continue every 2 months, or to initiate every 2-month cabrolpivirine with viral load monitoring every 24 weeks, which I'm sure gives everybody a slight feeling of anxiety. So confirmed virologic failure was defined as 2 consecutive viral loads greater than 200 copies, and resistance testing was done on archived samples at baseline and retrospective and at confirmed virologic failure. The initial week 48 data has already been reported for this. This is the 96-week follow-up data that they're presenting. So they had 512 participants. Sorry, the slides are not more exciting, but just a lot of information. Median age was 42, 58% were female, 92% on dolutegravir at baseline, and 74% with a history of prior NNRTI exposure, including 8% that had baseline archived rilpivirine resistance. The participants had high retention and 81% had on-time injections, very, very similar to what we see in the US-based cohort. And at week 96, the primary endpoint, 96% of those in the long-acting arm and 97% in the oral therapy arm had a viral load of less than 50 copies, meeting non-inferiority, which is like super exciting. 4 participants, or 1.6%, there's that number again, in the long-acting arm had confirmed virologic failure by week 96 and none in the oral therapy arm, and resistance was common at failure. 3 of those individuals resuppressed on dolutegravir 3TC TDF, and 1 participant passed away from surgical intervention. So here they're, despite the failure and resistance, they're going back to dolutegravir-based treatment with overall good efficacy. There was 1 serious treatment-related adverse event, an injection site abscess that led to discontinuation. So I think the way I would summarize the overall experience with rilpivirine is that there's going to be a discontinuation rate that ranges between 15 and 20%, regardless of who is initiating treatment, because maybe an injection sounds great until your butt is sore or whatever. You just find that actually going to clinic every 2 months is not as convenient as it originally sounded. I think in terms of the rate of this regimen failing and not people failing it, it seems to be very consistently at about 1.6%. This does not appear to be tied to whether or not the medication is administered on time, which is just continues to be something that I speak very openly with about my patients, because I feel very confident telling people that if they take their oral ART every day, they will not experience rebound. And I don't think that that's something that we can tell people about rilpivirine. And this is a personal discussion for patients, and there are certainly individuals who feel fine about a 1.6% rate of breakthrough. And the overall data is quite reassuring that probably those individuals can be resuppressed. And in particular, with our strategies of earlier viral load monitoring, it's unlikely to substantially even limit their options moving forward. So I think it's really remarkable that both the CARE study and the TRIO study come up with this exact same, essentially, rate of virologic, confirmed virologic failure. And I think I'll bring up one other thing, which is there was a session on Wednesday evening where they talked about integrase resistance, and there was a really remarkable discussion that emerged. So to me, so Monica Gandhi had mentioned that with the CARES data and the 8% baseline archived rilpivirine resistance, maybe we should be less worried about rilpivirine resistance for overall efficacy of treatment. Then there was someone who identified himself as being from the resistance mafia, who was a basic virologist who got up to ask a follow-up question and basically said, you know, some of these things that have been identified as resistance-associated substitutions are actually related to APOBEC hypermutation and the viruses that they are derived from. So APOBEC hypermutation is an immune response that occurs that just does exactly what it sounds like. It messes up the viral sequence so that even though it gets integrated into the DNA, it can't produce an effective viral particle. It's one of the host defenses that we have against virus infections in general. And so sometimes those random mutations, which cause certain specific types of substitutions, can also mimic what happens when there's sort of a targeted substitution leading to drug resistance. And so in the original report from the CARES data, there was a concern that some of the resistance sequencing likely was identifying APOBEC hypermutation and not actually true resistance mutations, and that those should be carefully separated in order to identify whether resistance matters or not. So I thought this was like a fascinating discussion because that's not anywhere in the papers for anybody to sort of see and read. And Nick Patton, who's I think the PI or one of the high up people from CARES, got up and said, you know, we have actually gone back and on the new analysis of the data have separated out those that we believe are arising from APOBEC hypermutation and those that are true mutations. And I think that the failure rate, what he said in the discussion was that the failure rate of those with true mutations, which aren't APOBEC hypermutation, there is a higher rate of failure. So that more will have to emerge on that. But I think as far as, you know, we've talked about many times on this conference, how to use proviral testing when we don't know what it means. And yet there is data suggesting that a baseline rilpivirine archive mutation is associated with a higher risk of rilpivirine failure when combined with another risk factor. So how to use that as we risk stratify patients for virologic failure and what these other larger data sets are telling us, I think there will hopefully be some more settling and clarity of that information in the coming years. But I don't know if anybody else, I did see Stu, who always has thoughtful, oh, but he may have left. But regardless, anyway, anyone have any thoughts or comments on all the rilpivirine data?
Thanks so much, Eileen. Yeah, this is really helpful, I think, in terms of helping us guide discussions with patients about this new option, obviously. And that, you know, sort of 1%, 1.6% is a helpful number to review, and depending on whether or not people struggle with oral medications, that may or may not be, you know, that's going to be important depending on their personal issues. One study and one thing is just about monitoring, you know, like monitoring, oh, this was the PrEP. I'm not sure if you're going to do the cabotegravir and like the monitoring for infection, but that's maybe a separate discussion. But that was related to the injectables, was just sort of monitoring for breakthrough infection and you know, what do we do with the results.
Yeah, no, and so I don't have prevention for today. I have one more little slide on, I think this next one's the last one. So I'll do this last one and then we can see if anybody has oh, it's 2, but whatever. So the really rapid review of new things on the horizon. So once yearly lenacapavir, so high sustained drug levels over 56 weeks with a novel formulation of lenacapavir. They were above that which is achieved with the every 6-month dosing and still 3-fold lower than their peak levels previously evaluated for safety. So there is currently a phase 2 trial of phase 3, I believe, sorry, I wrote 2, but I think it's 3, of once yearly PrEP with lenacapavir. So lenacapavir remains a drug that could potentially be a real game changer in HIV prevention. With treatment, we still have to get partners, but for prevention, very exciting. So there's abstract 152. This is a novel 3rd generation integration strand transfer inhibitor, which had a 2-log viral load decline at day 10 with no resistance. That's gone into long-acting development. And maybe one of these will be the partner that lenacapavir is looking for on the dance floor. And then abstract 153, which is a new HIV capsid inhibitor. So it's close to a 2-log decline at day 11. There was one of the participants in this small trial did experience an almost 4-fold loss of susceptibility, suggesting that it may not be as the high barrier as the 3rd-gen INSTI, but still also going into long-acting development. And with lenacapavir, we've seen some cases where there's resistance, but then resuppression. So I think, again, we're still learning to how we can interpret resistance in some of these novel drug classes. And then there were 2 abstracts on doravirine and islatravir. So islatravir is that novel non-nucleoside reverse transcriptase and translocation inhibitor. So it is similar to the nukes, but has a slightly different mechanism of action. And with that has some insulation from traditional nuke mutations. It also had like lots of promise for once weekly, once monthly dosing, but that was all canned because of a unexpected adverse effect of CD4 depletion seen with higher doses of islatravir. So at lower doses, when they weren't pushing to try to get longer exposures, it is well tolerated. And so now has been developed as a 2-drug option with doravirine. And these 2 studies presented results from switch to doravirine islatravir evaluations. So the first is a multinational switch study from BIC-F-TAF to DOR-ISL. Suppression for greater than 3 months was required, no history of treatment failure, no known resistance. And they did meet non-inferiority criteria to BIC-F-TAF with no treatment emergent resistance and no significant impact on lymphocyte or CD4 count. There was one serious adverse event adjudicated by the study investigator to be possibly treatment related, which was ITP. And they had this really interesting hepatitis B side note. So they enrolled hepatitis B core antibody positive individuals, so individuals who may have a history of hepatitis B infection. And they had one instance and then closely monitored them. I think trying to find a way around this like broad exclusion of hepatitis B experience and serotesting for 2-drug therapeutics. In one case, they did detect HBV DNA, but they did not detect antigen, which is kind of unusual. But they did find 2 new hepatitis B infections during the course of the study, which just made you want to scream about the Beehive trial and get all those individuals vaccination. But regardless, that was an interesting side note, and we will have to watch how different studies handle the inclusion or exclusion of hepatitis B, either experienced or naive individuals and not protected individuals moving forward. So the other abstract was like a paired abstract. It was like A and B. It was doravirine islatravir switch from any ART baseline regimen. In adults with HIV less than 50 copies for more than 3 months on 2 or 3 drug therapy. And among 500 participants, they had 40% female and 60% were non-white. And they again observed non-inferiority. There were 3 discontinuations with biologic failure. 1 failed to amplify, so likely was not that big of a failure. 1 did have resistance and undetectable drug at the time of treatment failure, so likely with adherence challenges. And 1 with an early failure with resistance-associated mutations, but then on review had prior failure of doravirine in the past. So this will probably be in the offing at some point in the near-ish future, and we'll see what niche it will fit. And then also some other new novel agents. So we are at the top of the hour. I'll stop sharing and just see if anybody had any questions or follow-up, and then we'll sort of shift back to doing more cases, but I'll sprinkle in some of the other data from prevention, and then there was some cure stuff. There's just so much to cover. So I'll sprinkle some more things in over the next few weeks as we do cases, but anybody with any thoughts or comments?
Great review, Eileen. Thank you so much.
Well, thanks everybody, and have a great week.
Thank you.
Thanks, Eileen.
Thanks, Eileen.